All right. So if you've been listening to the podcast and the review, I assume that you're pretty well prepared for your board exam. This is more of a last minute review series to kind of get all the important things together in a fast review for you to memorize everything going into the exam. So without further ado, let's go. All right, so a woman in her 40s of African American descent came with bilateral ankle pain that's going on for a few months. And you also notice that she has raised papules on her elbows, so erythema nodosum, and you get an x ray and she has hilar retinopathy. So, what's the diagnosis? I would say it's a flavor of sarcoidosis, I'll give you that. Yep, Lofgren syndrome. So, no disrespect to Dr. Lofgren. I'm sure he's a wonderful guy, but for my own memory, I like to remember this as Lofgren was a feet guy. So, that's why whenever you see bilateral ankle arthritis with erythema nodosum and hilar adenopathy, you think of Lofgren. Okay? And then how do you treat it? It's usually self-limited, but you can use NSAIDs for symptom control. Okay? Again, classic triad of bilateral ankle arthritis, erythema nodosum, and hilar adenopathy. Usually it's Lofgren. Okay. Unlike most autoimmune diseases, you don't need steroids. Just NSAIDs will do it for you. Okay. Moving on, let's say a patient with end-stage renal disease on dialysis presents to you and you check their routine labs and turns out their serum parathyroid hormone is high. What is this? This is secondary hyperparathyroidism from the ESRD, right? And their phosphate will probably be high too, because that's one feature of secondary hyperparathyroidism secondary to ESRD. So patient presents like that with high serum parathyroid hormone and high phosphate. What do? The first step you do is put them on phosphate restriction, so less than 900 milligrams of phosphate a day. Patient comes back 2 months later and parathyroid hormone and phosphate are either of them are still high. What do you want to do? You want to add a phosphate binder. Okay, so the next step is adding sevelamer or lanthanum. I've never seen lanthanum being ordered. I always see sevelamer. So next step is you'll add sevelamer to kind of keep that serum phosphate low. Okay. And then 2 months later, patient presents to you and their parathyroid hormone is still high. What do you do then? Because they're already on phosphate binders. So then you look at serum phosphate and serum calcium. So there are two ways to go about it. Patient has persistently high parathyroid hormone. He's already on sevelamer. There are two ways to go about it. If the serum phosphate and serum calcium both are less than 5.5 and 9.5 respectively, you add vitamin D or synthetic analog. Okay. Without going into the rationale, just remember, if phosphate is less than 5.5 or calcium is less than 9.5, you add vitamin D. Okay. But if phosphate is more than 5.5 and calcium is more than 9.5, you add cinacalcet. Okay, kinda random, I know, but trust me, you want to remember this. Again, patient with the ESRD and high phosphate, you add phosphate binder. Patient still has persistently high parathyroid hormone. You check their phosphate and calcium. If phosphate is less than 5.5 and calcium is less than 9.5, you add vitamin D. It makes most sense because vitamin D, you don't want to add vitamin D when calcium and phosphate are high, right? So the other scenario, if calcium and phosphate are high, so phosphate is more than 5.5 and calcium is more than 9.5, you add cinacalcet. So at the end of the day, the treatment of secondary hyperparathyroidism that's not responding to sevelamer in ESRD is depending on the levels of calcium and phosphate. Always remember that. Okay. All right. Patient who is an active smoker, a very extensive smoking history, and he's relatively young. He's 40 years of age. Presents with necrosis of the fingers, really bad pain, and the fingers are turning black, like acutely. What is this? This is Berger disease or thromboangiitis obliterans. This is different from Raynaud's disease, okay? This is like full-fledged necrosis, and the association that you want to remember is not hepatitis, smoking, okay? Speaking of, what's a similar looking disease that happens in hepatitis C? So a patient will present to you history of hepatitis C. they present with purpura, has to be like can be anywhere, doesn't have to be fingers, and also joint pain, and like their kidney function is bad, and they have a like glomerulonephritis like picture on their urinalysis, so they have like high amount of red blood cells and high amount of white blood cells. You check their serum complement level is low, and they also have neuropathy. So what's the diagnosis? Again, patient with hepatitis C, palpable purpura, arthralgia, membranoproliferative glomerulonephritis kind of picture, and low serum complement level. What is this? This is essential mixed cryoglobulinemia induced by hepatitis C. Okay, and this can also cause skin necrosis and gangrene. Okay, and how do you treat it? You treat the hepatitis C, you take care of the cryoglobulins in the blood, and you improve the skin symptoms. Okay, and then the third condition I want you to remember is a patient will present with palpable purpura and arthralgias and glomerulonephritis. They'll also have severe abdominal pain, and you'll check complement levels, and complement levels will be fine. What is this? This is henoch-schnoline purpura. So the classic symptom for henoch-schnoline purpura is abdominal pain and also normal serum levels, serum complement levels. Okay, so these are like different conditions that can cause necrosis of the fingers, so you'll have to differentiate come the exam. Okay, all right, patient presents to you with dry mouth, dry eyes, and like keratoconjunctivitis on eye exam. They also have history of SLE or rheumatoid arthritis or scleroderma. What are you thinking? Sjogren syndrome, right? So how do you diagnose Sjogren syndrome? So you can do a physical exam test called Schirmer test, which basically tells you that patient has decreased lacrimation. You can also check antibodies. So the antibodies you want to remember for Sjogren syndrome are anti-Ro and anti-La. Okay. And definitive diagnosis you can do with salivary gland biopsy. That's correct. And what will that show? That will show focal lymphocytic sialoadenitis, so inflammation of the salivary gland on biopsy. So that's how you diagnose it. But the things you want to remember are not the classic signs and symptoms of Sjogren syndrome, because if you've done residency, you like everybody knows it's symptoms, right? Dry eyes and xerosis and dry mouth and salivary hypertrophy. So what you want to remember are the extraglandular features. Okay, so what can Sjogren syndrome have outside of the classic symptoms? So as with most autoimmune diseases, arthralgia and arthritis. Okay, also cutaneous vasculitis. So don't be surprised if a patient has gangrene and they have a history of Sjogren syndrome. What else? Raynaud's phenomenon, of course. If they have fingers turning blue, that's also a possibility in Sjogren syndrome. Okay, and then interstitial lung disease. So what I like to think about is Sjogren makes everything dry, right? So I kind of like to think about interstitial lung disease as kind of a dry disease, right? Fibrosis and everything. So that's how I remember it. Sjogren syndrome can cause interstitial lung disease. And then lastly, if you get like a picture where a patient all of a sudden with history of Sjogren syndrome, all of a sudden they have a salivary gland swelling, or to be honest, like any swelling of any lymph node. So what's that? That's non-Hodgkin lymphoma, which makes sense, right? Because we just talked about how on salivary gland biopsy, patient could have focal lymphocytic sialoadenitis. So if you have like chronic lymphocytic inflammation of a salivary gland, you can develop like a lymphoma. Okay, so yeah, don't be surprised if you get like some vignette, clinical vignette, where it says patient with Sjogren syndrome all of a sudden started having like a submandibular swelling or something. Hope that makes sense. Moving on to some shoulder joint problems. So a patient comes to you with pain with abduction and external rotation. So you check their shoulder exam, and they have normal range of motion with positive impingement tests. So like positive near tests or Hawkins test, or like the test where you make the patient point their thumb down. So if that's positive, then what is this? This is rotator cuff impingement or tendinopathy, whatever. Okay. In contrast, Patient comes to you with a pain in their shoulder when they abduct or externally rotate, but they also have weakness of abduction and external rotation. Not just pain, they legit cannot move their limb. So that is different from rotator cuff impingement or tendinopathy. So what is that? That is a full-fledged rotator cuff tear. So to summarize, the difference between rotator cuff tendinopathy slash impingement and rotator cuff tear is that in rotator cuff tear you'll have weakness in addition to pain with abduction and external rotation. Okay, and then third condition, if a patient comes to you and they complain of shoulder stiffness and you check their range of motion both actively, like you ask them to move it, and passively, like you use your own hands to move their shoulder, and they have decreased passive and active range of motion, what is that? That's adhesive capsulitis. Okay, and then lastly, if a patient who's old and they just got like hit to their shoulder during a road traffic accident or something, and now they have like this like gradual onset of this deep aching pain on movement, and they also have decreased range of motion, so now you're thinking more of a glenohumeral osteoarthritis. Okay, but the thing you want to remember is that both rotator cuff tendinopathy slash impingement and tear present with kind of similar symptoms, right? Pain with the external rotation and abduction. However, the difference is that in rotator cuff tear, you will have weakness as well. Okay, and how do you treat these? Surgery. Okay, ideally within 6 weeks. Okay, all right. Hope you remember that. All right, 40-year-old woman presents with morning stiffness and arthritis that spares the like DIP joints. What is that? Rheumatoid arthritis, right? So you start them on methotrexate, and 6 months later they still have morning stiffness and they still have arthritis that spares distal interphalangeal joints. What is that? It means that whatever treatment you gave, methotrexate, is not working very well. So what are your options? There are two ways to go about it. Either you do step-up therapy where you add a biologic agent, like infliximab or TNF inhibitors, or there's a parallel therapy where you add a non-biologic agent such as hydroxychloroquine or sulfasalazine. Okay, so let's say you decide to do a TNF inhibitor on this patient because clearly methotrexate is not working. So you decide to go for infliximab. What you want to do? You want to check their IgRA, because if they have like latent TB and you give them infliximab, then the TB is going to reactivate. So remember that. Okay, and then let's say that 6 months later patient presents again, and even with methotrexate and TNF inhibitor they're not responding. What do you do next? You switch to another TNF inhibitor and you continue methotrexate. So that's the treatment for rheumatoid arthritis. Okay, again, rheumatoid arthritis, first time diagnosis, methotrexate, persistent symptoms, either do a step-up therapy by adding a TNF inhibitor or a parallel therapy by adding like a non-biologic agent such as hydroxychloroquine or sulfasalazine. And then 6 months later, if the patient doesn't respond, then you add another TNF, or like you switch to another TNF antagonist. And of course you have to check for TB and also hepatitis B and C prior to starting a patient on TNF therapy. Okay, all right, really quick, a patient presents to you with really severe flank pain going into the groin. You do a CT scan and patient has a stone. What do you want to do next? So the number you want to remember is 10 millimeter. Okay, so if the stone size is less than 10 millimeter and they don't have like acute renal failure or complete obstruction or urosepsis, blah blah, you can treat it medically. So how do you treat that? Alpha blockers, ask them to strain, ask them to climb stairs really fast all day so the stone passes by itself. Okay, and then what if the stone was more than 10 millimeter? Then you consult urology for possible lithotripsy or whatever they want to do, so surgery. Okay, and then going back to that stone, the one less than 10 millimeter that we were trying to treat medically. So let's say a patient comes back in 4 to 6 weeks, still having pain, the stone is still there, he hasn't seen anything coming out, and it's been 4 to 6 weeks. What do you want to do? It means that medical therapy has failed, so you again consult urology for a possible surgery. Okay. And then again, at any point, if a patient has a stone and on CT scan they have a complete obstruction, or if they have acute renal failure, or if they have sepsis, then you need to involve urology for a possible procedure. Okay. The number you want to remember is stones more than 10 millimeter, surgery less than 10 millimeter, and no renal failure, obstruction, or sepsis, medical management for 4 to 6 weeks, and if that fails, then surgery. Hope you remember it. Okay, moving on. All right, patient with long-standing diabetes mellitus comes with foot problems, and you look at the foot and it's a very funny looking foot. So like the arch is collapsed and it's like jumbled up. What is this? This is Charcot arthropathy, or neuropathic arthropathy, which makes sense, right? Because if you have diabetes, then you probably have impaired sensation and proprioception, and probably neuropathy, which would lead to repetitive bone and joint trauma without you realizing it, and you'll end up with neuropathic or Charcot arthropathy. What other conditions can cause this? So B12 deficiency, same idea. If you have distal neuropathy, then you won't be able to realize on time that you're having bone and joint trauma. What else? So tertiary syphilis, it can cause stapes dorsalis, and it can impair your proprioception / vibration sensation. So anything that can do that can cause Charcot arthropathy. Okay, so how do you treat it? So orthotic footwear, and of course surgical realignment if needed, and of course infection management if there is any. Okay, so yeah, Charcot arthropathy, remember that. Moving on. All right, so patient presents to you with recurrent oral ulcers or aphthous ulcers, and they're having it like more than 3 times per year. What are you thinking about? Behcet's disease. Okay, so that's pretty easy, right? So that's not what will be tested. The things you want to remember is that Behcet disease doesn't just cause recurrent aphthous oral ulcers. It can also cause urogenital lesions, such as like scrotal lesions in men and vulvar in women. It can also cause skin lesions, such as erythema nodosum, palpable purpura. It can also cause eye problems, such as like anterior or posterior uveitis, hypopyon, and retinal vasculitis. I purposefully didn't call it eye ulcers. I just called it eye lesions. Okay, and then what else? So as with most autoimmune diseases, it can also cause arterial vasculitis. So don't be surprised if a patient with Behcet disease all of a sudden gets necrosis of the skin. Okay, and then it can cause arthritis, and it can also lead to glomerulonephritis, and it can also cause gastric ulceration. So ulcers everywhere. Okay, and then one more interesting thing I want you to remember is that patient will have a positive P30 test in Behcet disease. Okay, what's that? You'll poke them with a needle, and then they'll get a papule about 24 to 48 hours later. That's called a positive P30 test, and it's classic for Behcet disease. And how do you treat Behcet disease? Steroids. Okay, so if it's just limited aphthous ulcers, you can just do topical steroids. But if it's like widespread disease with extra oral problems that we just discussed, you can also use systemic steroids. Hope that makes sense. Okay, moving on. So an 80-year-old grandma with history of osteoporosis has a ground level fall, and now she has a compression fracture. What would be the acute symptomatic pain control treatment? So of course, you'll try Tylenol and NSAIDs. If that doesn't work, then you'll go up on the WHO pain scale and try tramadol and opioids maybe. But if all of that doesn't work, what's one unique treatment especially for controlling the pain of a vertebral compression fracture? Starts with a C. Yep, calcitonin. So calcitonin is a second line treatment for anybody who has a compression fracture and is having uncontrollable pain. Calcitonin somehow works for it. Okay, so just something important you want to remember. Okay. All right, patient presents with chronic pain on the medial side of the knee. All tests, like ligaments and meniscal and this and that, all tests are negative, and it's this weird aching pain on the medial side of the knee. What's that? That's Pess anserinus pain syndrome, or as I would like to call it, Pess anus syndrome. Why? Because anus is medially, right? It's the most median organ, I would say. Not organ, but like most median structure in the body, I would say. And funny enough, the pain of Pess anserinus syndrome also presents on the medial side, pretty close to the a-hole, I would say. So that's why Pess anserinus syndrome, pain on the medial side of the knee. Pess anus syndrome, pain on the medial side of the knee. Okay. Treatment, same thing you do with most things, restricting the activity and also placing a pillow between the knees at night. That would make sense. And applying ice and NSAIDs, and if that doesn't work, then steroid injection. Okay. All right. Patient presents with these painful, tender, red-looking papules and plaques on the skin, and you do a biopsy, and it shows neutrophilic infiltrate. What is this? This is sweet syndrome, or as I'd like to call it, sweet neutrophil syndrome. Okay, it's just something I made up because I always forget what sweet syndrome is. So always remember this as sweet neutrophilic syndrome. Okay, and I personally like to think that neutrophils are pretty red. So the lesions would be like pink slash red slash erythematous looking. So yeah, anytime you do a skin biopsy on a red looking lesion and it shows neutrophils, that's sweet neutrophilic syndrome. Okay. Patient with rheumatoid arthritis for many years, all of a sudden develops a leukopenia on their routine CBC, like they went to the PCP and now their leukocyte count is low, and on exam they also have splenomegaly. So what is this? Rheumatoid arthritis with splenomegaly and leukopenia. Starts with an F. Yep, Felty syndrome. So just something to keep at the back of your mind. While we're at the subject, let's say a 25-year-old female all of a sudden for many months has had arthritis, and she also get recurrent fevers, on and off fevers, and CBC shows neutrophilic leukocytosis, and you also get inflammatory markers, and those are high. But here's the most important thing: you check for rheumatoid factor and ANA, both are negative, but ferritin for some reason is in the thousands. Okay, so what is this? This is adult-onset Still's disease. So the clinical features that are classic are arthritis in a younger female, high fever, and like a transient skin rash. Okay, so rash comes and goes, and then also patient can have lymphadenopathy, and worst case scenarios pericarditis and pleuritis and hepatomegaly and splenomegaly and sore throat. But the things you want to remember is young female, recurrent fevers, arthritis, and a transient rash, and also really high serum ferritin, but negative rheumatoid factor and negative ANA. Okay, and one fun fact: this was actually the movie plot of a movie called The Big Sick. It's really one of my favorites. Sorry to spoil you, but it's a good movie, so check that out. So I call it adult-onset Still's disease, the Big Sick disease, also known as systemic onset juvenile idiopathic arthritis. So kind of self-explanatory. Systemic onset because patient will have systemic symptoms. Juvenile because unlike rheumatoid arthritis, this kind of arthritis presents in a younger population, usually female, and idiopathic because we don't really know what's going on. And again, the most classic thing you want to remember is serum ferritin will be in the thousands for whatever reason. Okay, hope you remember it. All right, let's say a patient who has had rheumatoid arthritis for many years presents with the acute onset single joint pain. The joint looks swollen, tender, erythematous, really ugly. What's the best next step? Yep, you tap the joint. Why? Because rheumatoid arthritis predisposes to septic arthritis. Okay, and after you get the tap, what do you want to do? Then you want to immediately start on antibiotics and wait for the cultures. Okay, so here's the thing you want to remember: rheumatoid arthritis patients can also have septic arthritis, or they can also have pseudoseptic arthritis. So let's say another patient with rheumatoid arthritis for many years presents with a knee pain also, and you get a knee tap and the cell count is less than 50,000 and cultures don't grow anything. What is this? This is pseudoseptic arthritis. Okay, So remember that. Always in a rheumatoid arthritis patient, rule out septic arthritis by a joint tap if a patient presents like that, okay? Moving on, let's say a belly dancer or like belly dancer comes to you because they were dancing and they hurt their ankle, and now you see them grabbing their ankle and they're crying. And what do you want to do? You're an emergency doctor. So the question is whether you want to get X-ray of that ankle or just like call it an ankle sprain and let her go home with conservative management. So that's where Ottawa ankle rules come in, right? So in a patient with ankle injury, you only get an X-ray of the ankle if there is pain at the malleolar zone and the patient is either tender at the posterior tip of medial malleolus or posterior tip of lateral malleolus, or if they're unable to bear weight for 4 steps. Okay, again, patient comes with ankle injury, you get an x-ray of the ankle if there is pain at the malleolar zone, so like pain at the ankle, and they also have to be tender at either posterior tip of medial malleolus or posterior tip of lateral malleolus, or they're unable to bear weight 4 steps. Okay, and these conditions are mutually exclusive. So even if the patient doesn't have any tenderness on medial or lateral malleolus, but they're not able to bear weight for 4 steps, then you get an x-ray. Okay, and what if another patient who is a runner, they come in because they ran too hard or something and now they're grabbing their foot and they're crying and everything, and you're the emergency doctor and you're wondering whether you should get an x-ray or not. So according to Ottawa ankle rules, you get an x-ray of the foot if there is pain at the midfoot zone and there is tenderness over the navicular bone or base of the fifth metatarsal, or patient is unable to bear weight 4 steps. So the third condition is the same for both ankle injuries and foot injuries. Anytime patient is unable to bear weight for 4 steps, you get an x-ray. But the first two conditions are different. So for foot, the condition is patient is either tender at the navicular bone or at the base of the fifth metatarsal. Okay, and going back to the ankle, patient has to be tender at either posterior margin of medial malleolus or posterior margin of lateral malleolus. The rationale is that both foot and ankle, these points are kind of the most fracture vulnerable, and if the patient doesn't have tenderness at these points and they're able to bear weight, the patient probably doesn't have a fracture and you don't need an x-ray. Hope that makes sense. Okay, all right. A patient comes to you because they were admitted to the hospital or for a different problem and it showed elevated alkaline phosphatase, and patient has also noticed that their skull is kind of feeling funny for the past few months, and they're also having progressively worsening hearing loss. So what's the diagnosis? Elevated alkaline phosphatase, worsening hearing loss, and skull deformity. It's Paget's disease of the bone. Okay, so Paget, Dr. Paget was a very busy guy. So what's the other famous Paget disease? That's the Paget disease of the breast, right? Where patient gets a really bad ulcer over the breast, and that's coming from like an occult cancer that's just started to show up. So yeah, remember these two Paget diseases. And then what's the treatment for Paget disease? Bisphosphonates. But like if the patient is asymptomatic and the Paget disease doesn't involve the important sites like skull, spine, or weight bearing bones, then honestly you can just monitor it. Okay, so yeah, Paget disease of the bone, elevated elk phos, and symptoms of overgrowth of bone. So like if Paget disease of skull, then hearing loss, dizziness. Paget disease of spine and pelvis, you got spinal stenosis, nerve compression, bone pain. Paget disease of long bones, so like if you get a femur Paget disease, then you'll get increased fracture risk and bowing deformities. And then also long term, if like the Paget disease keeps going undetected and keeps getting all that increased bone turnover, you might get osteosarcoma. And then what does x-ray show? So x-ray will usually show osteolytic or mixed lytic or sclerotic lesions. But the things you want to remember is like most patients are asymptomatic and alkaline phosphatase is usually elevated, and calcium and everything else is usually normal. Okay, hope you remember all this. All right, let's quickly talk about some hip pain syndromes. So patient presents to you, they have tenderness over the superior trochanter, or like lateral hip pain. Okay, and if you put pressure on lateral hip pain, the pain is aggravated. Okay, check their range of motion, and they have normal range of motion with no stiffness. To summarize, patient has lateral hip pain that's aggravated by direct pressure. There is point tenderness at the trochanter, and the range of motion of the hip is normal. What is this? This is trochanteric bursitis. It's probably one of the most common hip problems. Okay, so what's the other problem that kind of sounds similar, and that's how they'll get you? So let's say another patient who's like 70-year-old, they've been having groin pain and they're also having morning stiffness, and on exam their pain is aggravated by movement. So if you rotate the hip internally or externally, it hurts, and direct pressure doesn't cause anything. Okay, so the pain is more deep, and direct pressure doesn't do anything, and sometimes the pain also goes towards the knee, so it doesn't always stay in the hip, it also goes towards the knee. So what is that? That's hip osteoarthritis. See how these two conditions are kind of similar sounding. So what are the differentiating points? So trochanteric bursitis will have lateral hip pain that's made worse by direct pressure, but osteoarthritis will have no such thing, like no impact with direct pressure. Also, trochanteric bursitis will have normal range of motion of hip, versus osteoarthritis, which will have like pain aggravated by internal and external rotation. Okay, so these are the two things that are most confusing. What else? So patient who wears like tight jeans or something, or who has recently gained a lot of weight from a medical condition, presents to you with burning pain and paresthesia over the upper outer thigh. So, and then like they don't have any motor symptoms, they don't have any lumbar radiculopathy, it's just very isolated burning pain and paresthesias over a very particular dermatome, which is the upper outer thigh. So what is that? Meralgia paresthetica. Okay, and basically the rationale is that they will make you think that it's lumbar radiculopathy, but the SLR test in meralgia paresthetica will be negative, and there will be no motor symptoms in meralgia paresthetica because it's being caused by compression of the lateral femoral cutaneous nerve. So remember that. Okay, compression of the lateral femoral cutaneous nerve, burning pain and paresthesia over the upper outer thigh, a patient has tight wearing jeans or something, meralgia paresthetica. Okay, and then lastly we have a patient who was recently in a road traffic accident, and 1 week later they present with really severe acute pain that started after the road accident and hasn't gone away. And you check their hip rotation, and just like osteoarthritis, they have pain with internal and external hip rotation. But unlike osteoarthritis, this is more acute, and this happened after a road traffic accident. Okay, and patient is unable to bear weight. Whenever you see in a musculoskeletal clinical vignette that the patient is not able to bear weight on anything, it's usually a fracture. So the answer is patient probably has an occult hip fracture, and they should get some imaging to rule that out and get it treated accordingly. Okay, hope it makes sense. All right, let's talk about gout real quick, specifically gout treatment. So there are two kind of treatments. One is for the acute flare-ups of gout, and second is the urate lowering therapy. Okay, so for acute flare-up of gout, you have three options. You can use NSAIDs, you can use colchicine, or you can use steroids, depending on the patient population. So let's say if it's a 40-year-old male, no history of anything, just literally just gout, you can simply use NSAIDs, or you can use NSAIDs plus colchicine. Okay, but what if a patient has chronic kidney disease with GFR of like, I don't know, less than 40 or something? Then you can't use NSAIDs, of course, and you can't use colchicine because colchicine is contraindicated in severe kidney disease. So then you have steroids. If the patient just has a gout in one of the, like only one joint, then you can do a steroid injection. But if they have gout in multiple joints, then you can use steroid, oral or like even IV if it's bad enough. Okay, so that's pretty much the gist of the flare-up treatment. Now we get to the urate lowering therapy. So if the patient is having frequent gout attacks, you have to start them on some kind of urate lowering therapy, right? But here's something you need to absolutely remember. Whenever you start them on urate lowering therapy, make sure that you're giving them a prophylactic flare up therapy, because sometimes if you start them on, let's say, allopurinol and without a gout flare prophylaxis, they'll most likely develop a flare up. So that is very important. Never start a patient with just allopurinol if like you're starting them on allopurinol for the first time, or other urate lowering therapies for that matter. Okay. And then what is the target level that we're using to lower the uric acid level? Less than 6 milligrams. So our target uric acid level is less than 6. Okay. Having said that, uric acid levels can be normal in extensive gout, and if the patient has tophi, right? Because all the uric acid has accumulated under the skin, under the tophi. So don't always rely on uric acid, rely on clinical picture. Okay, so to summarize, you got flare-up therapy, you got NSAIDs, colchicine, and steroids. Colchicine and NSAIDs not to be used in CKD. And then for urate lowering therapy, you can start a patient on allopurinol, but make sure that you're also giving a flare-up prophylaxis. Okay, all right, moving on. Let's talk a little bit about some common knee pain syndromes and injuries. So everybody knows knee osteoarthritis and knee septic arthritis. So we want to talk about that. So let's say a patient comes in with medial pain on the medial side, and there's point tenderness at Pess anserin. What's that? We literally just talked about it like 20 minutes ago. So earlier we talked about Pess anserin pain syndrome. This is Pess anserin bursitis. So anytime you see medial knee pain, it's something related to Pess anserin is what I'm trying to say. Okay. What about lateral side? So let's say a runner comes to you and they have pain on the lateral side of the knee, specifically tenderness at the lateral femoral epicondyle with flexion and extension. So that's iliotibial band syndrome. Okay, so it's also a common overuse injury, and location is very specific on the lateral femoral epicondyle. Okay, and pain on the lateral side of the knee. Okay, what about a patient who is a runner and they have poorly localized pain on the anterior side of the knee? And this is important. They have pain when they squat, and it's very vague and poorly localized. So this is patellofemoral syndrome, okay? Because patella is interior, right? And femur is interior. So this is patellofemoral syndrome and poorly localized anterior pain, and most common in runners. Okay, and then what about a patient who comes to you, they play volleyball and they have pain on the right below the patella, so not on it, not over the knee, just below the patella, and you do an exam and there is tenderness at the tendon insertion site at the inferior patella. What's that? Patellar tendinopathy. Okay, and it's most commonly in basketball, and pain will be at the inferior side of the patella. Okay, speaking of patella, a patient comes to you and they have like really bad tenderness, and they also have fever, and like the knee joint kind of looks sketchy. You're initially thinking septic arthritis, but you do a physical exam and there's anterior knee bogginess and tenderness, and patient also has fever, and patient is a housemaid. What is that? That is prepatellar bursitis, so housemaid's knee. Okay, so this can also get infected, so they'll make you think it's septic arthritis, but the exam findings won't be like an acute septic joint. Exam will show anterior knee bogginess and tenderness, and it'll be housemaid's knee or prepatellar bursitis. So yeah, just a few little overuse injuries related to the knee. To summarize, medial side of the knee, Pess anserinus; lateral side of the knee, iliotibial band syndrome; pain on the anterior side of the knee, patellofemoral syndrome, pain below the patella, patellar tendinopathy, and pain on the anterior knee with bogginess and tenderness and possible infection. That's Houseman's knee or prepatellar bursitis. Hope you remember it. Might as well give you like 5 points or something if you just manage to remember these somehow. I know we talked about rheumatoid arthritis treatment before, but what if a patient comes to you with the symptoms of morning stiffness, multiple joint pain and swelling, and morning stiffness improves and improves with activity. And of course, like on exam, there is no inflammation of the DIP joint. What's that? That's rheumatoid arthritis, right? But they also have a stiff finger, like one of their fingers is not moving, like it's very stiff. What's that? That's called the trigger finger, and it's a tenosynovitis of the palms. Okay. And then you're pretty sure that they have rheumatoid arthritis, so you order rheumatoid factor and anti-CCP antibodies, and both are negative. What? So what is that? That's still rheumatoid arthritis, but it's called seronegative rheumatoid arthritis. It's a variant of rheumatoid arthritis, and it has a much less aggressive course. So don't just rely on like rheumatoid arthritis and anti-CCP values. Patients can also have seronegative rheumatoid arthritis. All right, that is pretty much it. I'll let you go. You're probably very stressed due to the upcoming exam. And as always, you can buy me a coffee. My throat really hurts, and I'll see you in the next one, okay?